Hello students, this is Professor Roloff, and this is a lecture about gynecological concerns. There is a second part to this that will be given in class, but because we're missing class, we're doing this one as a voiceover PowerPoint. Next slide. This should be by now a review to you. There are 5 hormones that control or regulate the female reproductive system. In the brain, the hypothalamus produces and releases gonadotropin-releasing hormone, or GnRH. The GnRH then goes to the pituitary gland and causes the release of 2 more hormones, follicle-stimulating hormone, which is FSH, and luteinizing hormone, which is LH. The FSH and the LH then go to the ovaries and cause the release of estrogen and progesterone. Next slide. Again, this should be a review to you as well. You know that the menstrual cycle is a cyclical event that includes ovulation and the preparation of the endometrium for pregnancy. The events are measured from day 1, which is the first day of the woman's last normal menstrual period. The cycle is divided into the follicular phase, which is controlled more by the FSH than LH. It starts with day 1 of menstruation and lasts roughly till day 14. During this phase, the concentration of estrogen is rising, and it is preparing the ovaries for the next ovulation, which occurs on or about day 14. During this time, the endometrium is growing thicker and it becomes richly fed by blood vessels in preparation for possible fertilization and pregnancy. This is sometimes also referred to in texts as the proliferative phase. The next phase is the luteal phase, which is controlled by LH, and it starts around day 14-15 with the release of the egg. The corpus luteum releases progesterone, which makes the endometrium even more thick and rich with blood vessels in case the ovum is fertilized. If the ovum is not fertilized, then the corpus luteum degenerates and the level of progesterone starts to fall. The endometrium will then begin to disintegrate and the woman will have a menstrual period. And we have just completed 1 menstrual cycle. If the ovum is fertilized and the embryo implants in the endometrium and a placenta develops, then a different hormone, HCG, or human chorionic gonadotropin, is produced throughout the pregnancy. HCG, or human chorionic gonadotropin, will signal the corpus luteum to continue to supply progesterone to maintain nourishment to the endometrium throughout the pregnancy. It also acts as a negative feedback system for the hypothalamus and the pituitary gland, preventing the release of FSH and LH, and therefore further ovulation will cease. Next slide. Now, why is this important? It's important because this lecture is about gynecological concerns, and some of them have to do with menstruation. Statistics vary, but your C-Corps book reports that 1/3 to almost half of outpatient visits to an OBGYN are related to menstrual problems. That makes this important. First thing we're going to talk about is amenorrhea. Amenorrhea simply means the absence of menses. It's divided into primary and secondary amenorrhea. Primary is the absence of menses in a woman who's never had previously established menstrual cycles. And secondary amenorrhea is the absence of menses in a woman who has had previously established menstrual cycles. As you'll see as we start talking about it, amenorrhea is really a symptom or a consequence that is secondary to another diagnosis or another condition. The definition of primary amenorrhea also includes no menses by age 16, regardless of pubertal changes in the female, or no menses by age 14 with signs of pubertal changes, or no menses within 2 years of the start of puberty. What are some of the causes of primary amenorrhea? Well, first let me tell you that primary amenorrhea is relatively rare. Gonadal failure accounts for the vast majority, 45 to 60% of the cases of primary amenorrhea. Some of the causes are genetic syndromes, chromosomal abnormalities, things, if you've ever heard of them, like Blizzard syndrome or Turner syndrome or Swyer syndrome. Also, diseases that affect the hypothalamus and pituitary gland during embryonic development can cause primary amenorrhea. Gonadal anomalies include women that are born without a uterus or a vagina, or those born with ambiguous genitalia. All right, and you'll see some pictures of this on the screen in front of you. Next slide. Secondary amenorrhea is further defined as no menses for more than 3 consecutive cycles or more than 6 months without a period in a woman who has previously menstruated. Next slide. Secondary amenorrhea is most likely a physiologic cause. Now I have a picture here of a woman who is clearly pregnant, because the most obvious thing is to always rule out pregnancy, and this includes an ectopic pregnancy as well. But other causes of secondary amenorrhea would be lactation, menopause, some medications, obviously oral contraceptives, IUDs, the depot shot, but also some antidepressants, antipsychotics, some antihypertensives, and some allergy medicines may cause secondary amenorrhea. Chronic anovulation, ovarian failure, or hyperprolactinemia may cause secondary amenorrhea. These are all conditions that are due to problems with the HPO axis. HPO axis is the hypothalamic pituitary ovarian axis. Go back to that very first slide, and that is the HPO axis. Other causes of secondary amenorrhea may be due to some endocrine disorders. So thyroid diseases, hypothyroidism, a pituitary tumor, polycystic ovarian syndrome or PCOS, which we'll talk about later in the secondary part of the gynecological concerns, severe obesity. Also, there may be some conditions that we term outflow obstruction, things like an imperforate hymen, cervical stenosis, or a transverse vaginal septum, and I have some pictures to show you of that. Rapid weight loss or chronic anorexia can cause secondary amenorrhea, and good old stress can cause secondary amenorrhea. Next slide. So what is the workup that's involved in amenorrhea? You're going to do a good history. You need a thorough menstrual history. You need to know the sexual and contraceptive history. You need to know the OB history. How many pregnancies, any abortions. You need to know the woman's past medical and surgical history and any medications that she is currently taking. When you do your review of systems, you want to ask about weight changes, eating disorders, and some lifestyle stressors. On physical exam, look at the woman's general appearance. If it's a patient that you've seen previously, look for any changes in weight. Look for thyroid nodes, discharge from the breasts. On your speculum exam, is the vagina atrophic? Is the cervix scarred or stenosed? When you're doing the bimanual exam, is the uterus enlarged? When you're feeling in the adnexa, are the ovaries enlarged? What about lab and imaging studies? Well, you're always going to do a pregnancy test first. You're going to do an HCG qualitative and quantitative. Other studies that you'll likely order are a TSH, a prolactin level, FSH and LH, testosterone, and DHEA, which is a hormone produced by the adrenals and is a precursor to the male and female sex hormones, testosterone and estrogen. You're going to do a pap smear, you're going to get a CBC, a coag profile. Down the road, you may be doing karyotyping, which is an analysis of chromosomes looking for chromosomal anomalies. And imaging, you might do an ultrasound or an MRI looking at the genital structures. Next slide. I mentioned the word outflow obstruction as one of the causes for amenorrhea, and this is a picture of an imperforate hymen. An imperforate hymen is an abnormality in the development or canalization of the Mullerian ducts. A failure of the urogenital sinus and vaginal vestibule epithelium to fuse during embryonic development, and you do not have to memorize that. You would likely do an ultrasound to evaluate the genital tract on this patient. And then treatment would be surgical incision of the hymenal membrane and drainage of the vaginal canal. And just as an aside, imperforate hymens can be associated with endometriosis later on. Next slide. Here's another example of outflow obstruction. And this is cervical stenosis, which is a narrowing of the cervical canal, either congenital or acquired, and may result in a partial or complete obstruction. Stenosis occurs most often in the area of the Oz. And this can happen from operative damage, infections, radiation, neoplasms, atrophy, rarely congenitally. You're diagnosed with it when you're unable to pass a small diameter, 1 to 2 millimeter probe beyond the inner os circle. You may see, if you do an ultrasound, uterine enlargement. And how do you treat this? You use progressive dilators on the cervix under ultrasound guidance, and you might possibly place a cervical stent for several days. Next slide. So how do you treat amenorrhea? Well, you want to determine the underlying cause, and then what therapy you decide upon should be tailored to that cause and the needs of the patient. The big question that you find out from the patient is, does she desire pregnancy? If pregnancy is not desired and all pathologic conditions have been ruled out, then you can just provide reassurance to the patient, and no specific therapy would be needed. In primary amenorrhea, infertility is common. However, if the woman does achieve a pregnancy, there are no ill effects except for those that would be imposed by whatever the underlying cause is. In secondary amenorrhea, most causes may be successfully treated with the return of menstruation. If the physiologic reason for the amenorrhea has been discovered and corrected, and the woman is still not having menstrual periods, then the treatment is focused on restoring or inducing ovulation if the woman desires to become pregnant. Next slide. If all pathologic causes have been ruled out and a woman desires pregnancy, you will need to determine if she has anovulation, which is the absence of ovulation in a woman of reproductive age, or does she have ovarian failure, which is failure to induce ovulation in a woman of reproductive age. Next slide. This is I'm going to talk about the progesterone challenge test because you will still read about it and see it in texts, and it may be on the boards, but truly it's not used very much anymore because we now have readily available, more sophisticated methods to measure serum hormones, such as estrogen. So remembering that the menstrual cycle is a negative feedback system in which the rise or fall of one body hormone stops or starts the production of another hormone. Estrogen, which is produced in the ovaries, promotes the maturation and release of an ovum in every menstrual cycle. The concentration of estrogen rises in the ovulation or proliferative phase, which causes the endometrium to grow thicker. So what we're going to do is to do a progesterone challenge test to try and determine, is the estrogen priming the uterus? So if you were going to do this, you would give the woman some type of progesterone, such as medroxyprogesterone acetate or Provera, more commonly known, 5 to 10 milligrams by mouth every day for 5 to 10 days, and then tell her to stop. Next slide. If the woman has a period, or if bleeding occurs 2 to 7 days after the withdrawal of progesterone, this means that the woman is producing estrogen and the endometrium is functional. If a woman with anovulation wanted to become pregnant, you would likely have to induct ovulation with medications. We would certainly be referring her to an OBGYN or a fertility specialist. Next slide. If the woman does not experience bleeding 2 to 7 days after the withdrawal of the progesterone, you would want to draw an FSH level. Then you're going to initiate a course of estrogen, or you're going to prime, we call it priming the uterus or priming the endometrium. And then you're going to repeat another course of progesterone. If the woman's FSH is elevated after this and still no bleeding occurs, then this is considered ovarian failure. Now, if the woman is greater than 40 years of age, what do we call this? Menopause. But in a younger woman, this is considered premature ovarian failure, and she would be the one that would need chromosomal analysis or karyotyping and referral to an OBGYN that specializes in this. And this requires a lot of sensitivity on the part of the provider when telling the woman of these results. All right, so let's now talk about another menstrual disorder called abnormal uterine bleeding. Of all the menstrual concerns that women go to see their provider for, abnormal uterine bleeding is by far the most common. And what is abnormal uterine bleeding? Any uterine bleeding that occurs outside of the normal menstrual parameters. Some of these parameters, and again, this is not a black and white definition. All right, so some of the parameters referred to are duration. So a period that lasts less than 2 days or more than 7 days. Menstrual flow. Now it's hard to quantify that because nobody measures their menstrual flow. But you'll see in textbooks, but it's flow that's greater than 80 milliliters. What you'll find providers asking patients is, how many pads are you going through, or how many tampons are you going through? How often do you have to change them? Another parameter is cycle length. So a cycle length that's under 24 days or over 35 days, according to your Secor book. Other sources say under 21 days, given that the average cycle is 28 days, plus or minus 7 days. And then the last parameter is any so in between periods, intermenstrual bleeding or postcoital bleeding and spotting. Postcoital meaning after sex. Women are going to have differing opinions on what is excessive. So to me, it's relevant if it's disrupting this woman's life. So if it's causing her enough concern that she comes to see you for it, then it's relevant. Next slide. What's the epidemiology of abnormal uterine bleeding? It's very difficult to give an accurate number of cases due to the variations in nomenclature that are used to describe or diagnose it. All right, you may have heard the term dysfunctional uterine bleeding in reference to abnormal uterine bleeding, or menorrhagia, which means heavy menstrual bleeding, or metrorrhagia, which means irregular bleeding, or amenorrhea, which we just talked about. The Fédération Internationale de Gynecologie des Obstétriques, or FIGO, let's call it, came up with a new name, abnormal uterine bleeding, to replace all the others, and a classification system for abnormal uterine bleeding that we're going to talk about. And this was around 2014 that they came up with this. So prior to that is when you heard all of these different terms. Now everybody should refer to it as abnormal uterine bleeding. There's roughly 1.4 million cases of this reported a year. It's increased during adolescence and perimenopause. And why would you think that? The answer is hormones. There's a lot of hormonal changes during adolescence and perimenopause, which then can affect a woman's bleeding. Abnormal uterine bleeding is reported more commonly in obese women, Caucasian women, and young females. Next slide. The Fédération Internationale Gynecologique des Obstétriques, or FIGO, came up with acronyms in order to help identify causes of abnormal uterine bleeding. This first acronym is PALM, P-A-L-M, and this refers to structural disorders or causes of abnormal uterine bleeding. Now, certainly, when a woman presents to you for this, the first thing you're always going to do is what? Rule out pregnancy or a miscarriage or an ectopic pregnancy. So that's always your first line in any woman that presents to you with any kind of an OBGYN complaint. So, assuming that that is not the case, P stands for polyps. So polyps can certainly cause abnormal uterine bleeding. A is adenomyosis. This is a condition in the uterus where the inner lining, which is called the endometrium, breaks through the muscle wall, which is called the myometrium. L is for leiomyomas, or another name for them is fibroids. Submucosal fibroids in particular can cause abnormal uterine bleeding. M is for malignancies and hyperplasia. These can also cause abnormal uterine bleeding. Next slide. COIN, or COEIN, is the other acronym that FIGO developed to help identify non-structural causes of abnormal uterine bleeding. So C is for coagulopathy, or bleeding disorders. So any kind of a factor disorder, von Willebrand's, platelet disorder, hematologic disease, leukemias can all cause abnormal uterine bleeding. O is for ovulatory dysfunction. So we just talked about anovulation. Anovulatory cycles are the most common cause of abnormal uterine bleeding. There's many causes, but especially the endocrine disorders, the hypothyroidism, the PCOS, hyperprolactinemia, adrenal hyperplasia, Cushing's syndrome, the anorexias or extreme weight losses can cause AUB. Endometrial disorders itself, so any kind of an infection, endometritis. I think you heard from Professor Bush that STIs cause tissue friability, cervicitis, vaginitis, endometritis. So all those tissue changes, tissue friability due to infection can cause abnormal uterine bleeding. I is for iatrogenic causes. So some of the things under this category are medications. So some hormone therapy, oral contraceptives, SSRIs, antipsychotics, anticoagulants, some steroids and herbal supplements, or an IUD. These can all cause abnormal uterine bleeding. And then N is for not classified. And this involves things like stress. Stress can cause abnormal uterine bleeding, any renal or liver disorder, a mucosal disease such as Crohn's disease, trauma. Sometimes intercourse can be rough and cause bleeding, or sexual assault. You can get abrasions or lacerations in the vagina, and these can bleed, or a foreign body in the vagina. So these are all non-structural causes, because if we get rid of these or fix them, treat them, they will go away. Next slide. Diagnosing abnormal uterine bleeding is challenging. All right, determining the cause of AUB is really complex because it encompasses an enormous scope of medical problems, surgical problems, and even some psychological problems. The diagnosis is usually made by exclusion, so we call it a diagnosis of exclusion. You can start to form a differential diagnosis by knowing that certain diseases or conditions are more common within certain age groups. Next slide. This is a key point. This is something that you need to know. You will see it again in testing situations. You'll see it on the boards. But you must always consider malignancy when you have a woman who is postmenopausal and comes to you for bleeding. Bleeding in a postmenopausal woman is considered malignancy until proven otherwise. Key point. Next slide. So let's look at some of these age groups and some of the causes of abnormal uterine bleeding that go with different age groups. So if we're talking about prepubertal females, it's pretty rare to have bleeding. So you have to think trauma. Is this a sexual assault, or did they fall and have some kind of a straddle injury or an injury that is causing bleeding? Is there a foreign body in their vagina? Do they have an infection? Is there a urologic problem? When little girls get urinary tract infections, as same as adults, sometimes they bleed, and parents or the child can't really determine where is this blood coming from. They just see it when they're wiping or in their underwear or in their diaper. Is the child going through precocious puberty, which is fairly rare, but you will see this occasionally. So the child will have signs of puberty well before the age that they should be going through puberty, and this may lead to some abnormal uterine bleeding. In a neonate, you might get a frantic mother bringing her, 4, 5, 6-day-old in to you and saying, there's blood in her diaper. That is just estrogen withdrawal. That is a normal finding. Next slide. Next age group that we're looking at is the adolescents or teens. Anovulation and PCOS are the biggest causes of abnormal uterine bleeding. But coagulation disorders, stress or extreme exercise, certainly pregnancy, infections, and trauma also could be your causes. In this age group, neoplasm is relatively rare. Next slide. In the reproductive age woman, there's a whole host of potential causes of abnormal uterine bleeding. So anovulation, which we've talked about, pregnancy, infection, benign growths, medications, coagulation, endocrine disorders, liver disease, malignancy, trauma, stress, and extreme exercising. Next slide. And the woman who's in the peri or post-menopausal years, anovulation, certain medications, certainly malignancy, and put big stars next to that, benign growth, and atrophy. Neurologically, is she dizzy? Ask her about any skin bruising. Ask her about any joint pain, swelling, stiffness. All right, you are going to have to do a full gynecologic history on this woman. The history on a woman who presents with abnormal uterine bleeding, just so you know, should take you a long time. It should, because there's so much you have to ask. So you want to know the pregnancy history, you want to know her menstrual history, you want to know her sexual history, you want to know how many partners, did she have a recent partner, does she have sex with men, women, both? Does she have any new kind of sexual activity she's engaging in? Is there any risky behavior? Does she have any history of STIs? Any gynecologic surgery procedures? What's her personal gynecologic history? Does she douche? Does she use tampons, pads? You need to ask her about her social and family history. Does she have any history of sexual abuse, physical abuse? What's her lifestyle, her diet? Does she excessively exercise? Is she sleeping okay? Does she use drugs? Not only normal medications, but any illicit, any over-the-counter? Does she smoke? And the list goes on and on. There's a very nice chart in your C-Corps book that goes through all of the things that you need to ask when you're working up a woman with abnormal uterine bleeding. But history will be your most important tool. Next slide. Physical exam, you're going to look at her vital signs. All right, look at her blood pressure. All right, is she hypotensive? Check her vital signs for orthostatic vitals. Note any weight changes, changes in her BMI. On general appearance, look at her skin, hair, and distribution. Does she have any hirsutism, which goes along with PCOS, polycystic ovarian syndrome? Make sure you check her thyroid. Are there any nodules? Particularly look at breasts for discharge. Do a cardiac assessment looking for murmurs, tachycardia, rhythm changes. When you do your abdomen, pay particular attention. Is there any hepatosplenomegaly? Do you feel any masses? Does she have ascites? You need to check her rectum. Is there any bleeding at the rectum? And you should do a hemocult. You're going to do a pelvic exam. All right? First, look at the external genitalia. Can you see a source of this bleeding? You're going to do a speculum exam, except on the prepubescent females. And you're going to look at the cervix, the vaginal walls. You're going to collect cultures, do a pap smear. Do a wet mount if you have the capabilities. Assess for cervical motion tenderness when you're doing a bimanual. Does she have any adnexal tenderness? What is the uterine size, shape? Is it firm? Is it boggy? And you're going to also, like I said, do a rectal exam. Does she have any lesions, hemorrhoids? Is the hemocult positive? Next slide. Now you've got to come up with a differential. Put your thinking cap on. All right? What is the age of your patient? And is this bleeding a structural? Is the cause of this bleeding structural or non-structural? In your book in C-Core, there is a table that puts some of the most likely cause of abnormal uterine bleeding based on the age of the patient in order. So what I usually do is I think, okay, based on the history, the physical exam, the age of this patient, is this most likely structural or non-structural? Next slide. Diagnostic testing. There are way too many diagnostic tests to review here, mainly because the differential diagnosis for abnormal uterine bleeding is so vast. But some general guidelines are, if you are thinking POM or a structural cause of this abnormal uterine bleeding, think C. All right? It's something that you should be able to see. And if it's something you should be able to see, then to me, that means imaging. So think ultrasound, transvaginal ultrasound, MRI, CAT scan, sonohysterography, hysteroscopy, an endometrial biopsy. Any of those things, usually an ultrasound or transvaginal ultrasound, is what we go to first. If you are thinking coin or a non-structural cause of this abnormal uterine bleeding, then think lab work. In reality, there are a lot of patients that there's a combination of structural and non-structural. So you are doing both imaging and lab work. Next slide. Key point, again, you will see this. Endometrial biopsy is needed for all postmenopausal women with abnormal uterine bleeding and for women over the age of 40 who are presenting to you with abnormal uterine bleeding. Why? That is because bleeding in a postmenopausal woman or abnormal uterine bleeding in a woman older than the age of 40 is considered malignancy until proven otherwise. So bleeding in a postmenopausal woman or abnormal uterine bleeding in a woman greater than the age of 40 is considered malignancy until proven otherwise, and she will need an endometrial biopsy. Next slide. The type of management that you choose for the woman with abnormal uterine bleeding depends on so many factors. After you've ruled out pregnancy and you've ruled out malignancy, then what's the cause? What's the age of the female? Is she childbearing? Does she want to become pregnant? You will tailor your therapy to the cause of the bleeding as well as to the other factors that are involved. All right, I like to use the word management instead of treatment because in some case there might be no treatment per se, and what you are really doing is managing the bleeding. The goal, after pregnancy and malignancy have been ruled out, is to minimize blood loss and improve the quality of the woman's life. Next slide. Here are some of the most common management options. Again, this is completely dependent on the cause of the abnormal uterine bleeding. Most women can be managed with medications, but some may need a surgical procedure. So what kind of medications? All right. Bolded are the most common. So combined oral contraceptives, the POPs, the Depo, the hormonal IUD. Hormonal contraceptives are used to control bleeding and regulate periods. You've heard Professor Bush say that when she talked about contraception. They are used not just for contraceptive purposes, but they are also used to control abnormal uterine bleeding and to regulate periods. NSAIDs are also used to control bleeding and cramping. What else? Some of the surgical options are an endometrial ablation, surgical excision of a polyp or removal of a leiomyomata or a fibroid, uterine artery embolization, high-intensity focused ultrasound, and as an absolute last resort, a hysterectomy. And I can say that's rarely done. So lots of management options, but know that the most common are medications, meaning hormonal contraceptives and NSAIDs. Next slide. It's very important to follow up with these women. You do not want to lose them. Things that you want to follow up and check on are anemia. Was your patient anemic? Are they becoming anemic? Did you put them on iron? You want to follow their H&H, help them deal with the side effects of iron, mainly the constipation. Is the therapy that you recommended helping to regulate their menses? And if you did any kind of biopsies, what is the result? So these are women that are going to need probably multiple visits to see you, to figure out the cause of their abnormal uterine bleeding, but then to figure out the right treatment. So it's something that if you work in women's health or in a family practice that sees women manages minor OBGYN issues, you will definitely come upon this. All right, next slide. We will talk briefly about dysmenorrhea. It is the occurrence of painful menses, as you can deduct from the picture of the woman. Dysmenorrhea is divided into primary and secondary. Primary dysmenorrhea is recurrent, crampy, suprapubic pain, usually during the first few days of menses. It's most common in the first 3 years of the start of menarche, but may occur anytime during childbearing years. The key is that it is in the absence of any pelvic pathology. Secondary dysmenorrhea is painful menses due to some sort of pelvic pathology. One of the causes you've already learned about from Professor Bush, that is PID, and others we'll get to in later lectures. But for now, I'm just going to talk about primary dysmenorrhea, since it is related only to the menstrual period and not to any kind of pelvic pathology. Next slide. So primary dysmenorrhea is caused or thought to be caused by the overproduction or heightened response to endometrial prostaglandins. Remember that prostaglandins are produced in the uterine lining and released into the bloodstream as the lining is shed. So this causes smooth muscle contraction. But it can also cause cramps, nausea, diarrhea, back pain, headache, bloating, etc., etc. All the things that women complain about. If a woman complains about dysmenorrhea after years of having pain-free menses, think that she may have endometriosis. So prostaglandins is the culprit. Next slide. So if the cause of dysmenorrhea is prostaglandins, then what do you think the treatment for dysmenorrhea is? NSAIDs. And why? Because NSAIDs are prostaglandin inhibitors. So your first line treatment for a patient who presents to you with dysmenorrhea is going to always be NSAIDs, assuming they don't have any allergies to them. Other things that you can recommend are exercise. Gentle exercise definitely does help with cramping. I know a woman is not going to be wanting to exercise or may think you're crazy for telling her to exercise, but exercise definitely does help with cramping, with dysmenorrhea. Warm packs also help. Sometimes putting a woman on COCs or combined oral contraceptives helps. And then I put TLC for tender loving care. Everybody's pain threshold is different, and everybody's tolerance to dysmenorrhea is different. I think every woman experiences a little bit of discomfort around her period. It just may bother some more than others. So everybody deserves to have a little tender loving care. Next slide. So hopefully you find this as funny as I do. But we're going to talk very briefly about premenstrual syndrome. So my typical day of PMS, I eat all food, I cry about it, then I get mad at all the people, and then I cry about that, and then I just do it all over again. Next slide. There is really no diagnostic criteria for premenstrual syndrome or PMS. To be considered PMS, generally more than one of these symptoms are present 5 days prior to the start of menses and then disappear within 4 days of the onset of menses. So some of the symptoms are breast tenderness, abdominal bloating, headache, fluid retention, cravings, fatigue, irritability, angry outbursts, anxiety. There's all kinds of symptoms that women will say occur prior to the onset of their period, and that's how they know they're getting their period. Why does this occur? Again, it's thought to be due to luteinizing hormone and progesterone. So what do you do, or what do you tell these women? NSAIDs, because it's a prostaglandin inhibitor. Exercise, try to limit their salt intake, warm baths or warm packs, drink lots of fluid, and sometimes oral contraceptives are necessary. I have known some women to be placed on SSRIs for depression or anti-anxiety medications for irritability and anxiety, but this is rare and certainly wouldn't ever be your first line of treatment for PMS. Thank you, and this is the end of Gynecological Concerns Part 1.